I could do a Levine impression because I feel like he has such a stately way of communicating, but I will do my very best. I am excited about today for a couple of reasons. One is this is getting really real because we're closing in on the end. And I think we're in a decent spot today to talk about some tangible things that we've accomplished. And also, one of our goals today is to talk about some really intangible things that we are intending to accomplish. And I think we have some grounds to say we're getting there. And so, my fearless, Kathy and Mo have really been the brainchild. I feel like is such a paternalistic word. So I'm going to say innovative thinkers on how we communicate this information and how we pull this group together. And Kathy's been such a stalwart, and we are not doing PowerPoint presentations. This is not going to be a space where people come and listen to, to this spewing information. Today is the exception, and only for the very beginning. And I think what we've thought about today is there was some information on kind of how things tie together and specific recommendations that we want to give you a few ways to digest. And I think seeing them is going to help. So we thought we'd start off the morning by talking about the report and where it stands and kind of really hone in on making sure people in this room understand what we've said we're going to do. And, you still have time and a chance to adapt this language, to modify it, or to tell others you're planning on doing it. And so this is our time that we wanted to put it forward to everybody to make sure we're all on the same page. So Kathy, if you want to go to the next slide, we'll talk a little bit about the different work groups. So we want to make sure everybody's aware that the integration of primary care work group, their current language in the report says that they're going to pursue the implementation of a mental health peer or community health worker in a primary care practice as a single point of entry that's person-centered, equity-based, wellness-focused, and according with Vermont laws regarding parity. So currently, that is the work group's charge. There's lots of other pieces that work group is talking about and, trust building, infrastructure building, but this is the language of kind of the what we're considering a bit of a pilot. And I think I want people to know that in the other work groups, we're talking about these things. So I sit on the workforce development group, and one of the peer leaders in Vermont, Kareem Chapman, was saying in our group, hey, I wonder if we could ever pilot utilizing a peer in a primary care office. And I said, hey, great idea. They're actually planning on doing this. And how can you connect with them? So we're really trying to connect those dots as best we can. But if you're somebody who wasn't aware that Group 1, the integration of primary care, is doing this work, hopefully now you know. And anywhere you can connect dots, please do so. For number 2, the integration of pediatric care work group. This one's focused on incentivizing with resources. And they did identify that means both financial and implementation assistance. Integration of mental health within primary care serving child, youth, and family through pediatric specific applications of the locally selected integrated care models to ensure wellness rather than focusing on responding to problems. And the second piece for their work is to increase integration of healthcare and coordinated services planning for children and youth with disabilities. I don't know if everybody here is aware of what coordinated service planning is. So I'll just give a brief, in the child and youth serving system, when there's lots of complex needs for a child, we try to bring together the group of different serving agencies to say, is there anything else we could do for this youth and bring resources to the table? It's it's a wonderful process and one that requires integrity to it in order for it to go well. And so where it tends to fall down is sometimes we don't have, the right family advocacy in there, or we can't get everybody to the table, or maybe um, there isn't a resource in the community that everybody knows that's needed. So this is coordinated service planning is something that Vermont has tried to work hard to make sure that we're doing it well. And the goal is to make sure we're holding kids in the community rather than sending them to residential, especially residential out of state, and identifying if we need to send people to residential out of state, what do we need to put in the community for them to be able to come back? So those are all things that this group is charged with. And I think increasing integration of healthcare in there could be really beneficial as we, work to bring resources to bear. They have not, prior to this, been at the table. I am going to say for the beginning piece, I know there may be questions. And so if you have a targeted question about this, you could email Kathy and we can get those questions answered. But if there's anything I'm saying that's confusing, or if some people in the group know better than I when I'm explaining this, please do raise your hand and correct me or elaborate. Otherwise, I'm going to go through the other two work group recommendations. So integration of funding and alignment for performance measures work group. Steve DeVoe is a lone wolf now. He lost his partner in crime with Ina Backus, who has now gone on to work at the more federal level. So, but this group has worked hard to come up with some plans. And what you're seeing here is they're going to conduct a formal needs assessment to assess the parity of covered services by Vermont's health insurance payers. That's a big one. And the use of performance measures across healthcare providers and organizations, state government entities, and health insurance payers. A pilot selected integration care models using rigorous improvement science methodology in order to study the effect of healthcare delivery funding and any improvement on established performance measures. So I think this is one where this is something we say we're going to do, but I also want to highlight that there's also a lot of spaces where we are doing this. And so I would call it new for us to, and it's been pointed out to, I'll just name myself, since I took on the role of deputy commissioner and talked to different program directors and people out in the field, they've been clear to say, I think it's great that we're being innovative and moving towards value-based payment. Could you do me a favor and talk to the Department of Substance Use or Dale or OneCare, or because you're both asking sort of the same thing, completely different measures, completely different timelines. So I guess this is me saying, we hear you, and it's really complicated, right? Especially when we have to fold up to our people in the sky with CMS, and people have different agendas. And so I really appreciate the work that this group is looking to do, and I think could state we still have a ways to go. Performance measure group, is there anything you would add to that?
No, I think you did an excellent summary, Allison. Thank you.
I didn't do a terrible job. Okay. I'm going to keep going for the last one. This is the integration of workforce development work group. So Kaya and myself chair this group. We've had wonderful participation from lots of different perspectives and disciplines. I want to thank Dan Toll, who joined the group partway through because we were struggling to get regular participation from peer leaders in Vermont, and it's been really beneficial to have him there. One of the first pieces we identified is let's not totally recreate the wheel. So Kaya is also a leader on the Health Equity Advisory Commission. And that group has identified lots of professional workforce development areas of need that get at equity, parity, and making sure that we are elevating all individuals professionally and serving all individuals. So we were able to take a lot of that work and align it where appropriate. There are still plenty of gaps, and I think that's what our group is trying to look for. So one of the things, and I've learned this, I feel like shared staffing has now become like a bad word. People get a little like, oh, really? We're going to share staffing as if that's going to solve a problem. I don't have a staff to share. So I'm going to call it leverage staffing, which is really let's identify some areas where we can work through contracting and partnering versus building on our own. And so in our group, we have representation from FQHCs. We've got the designated agencies. Julie Tessler is a part of our group. We're talking about what CCBHCs can do or can't do and how it might push us in the direction we want to go, and what type of people we would need in order to do that work. We've had a lot of conversations in the group about the definition of peers and how that word's being used, and where we might need to change the word or define it better in different settings, such as healthcare, for example. And so one of the things that we're also looking at is how can care be best served in the different spaces where somebody might enter. So I think it's, as someone who focuses on resources a lot every day, how can we build an FQHC and a CCBHC, and how would any person know what door might I want to enter to be best served, or that has the type of approach that's going to meet my personal needs? And so how do we help message that, set it up that way, and also make sure that they're connected so they're not two separate worlds? So those are the kind of conversations that we're having in our work group, as well as some guiding principles for workforce development. I think one of the big debates our group gets in is there's whole person care, but also as providers and as people who go out and get educated for certain specialty, we don't want to dilute that specialty, and we want to honor the fact that there is this particular approach to, say, substance use recovery, and that we may want to preserve that approach, but also ensure that they might be able to identify other needs, versus having every provider be in charge of saying a whole person's care without any specialty involved. And so we haven't solved for that, but that's kind of the conversation that we're having in that group. So those are all 4, right, Kathy?
Yes, yeah, that should be, that's the 4.
Oh, if you're talking, I can't hear you, but I'm going to pause there.
Can you hear me now?
And ask if anyone from the work groups has anything they might want to add before I move forward. Okay, going once. All right, so I will say again, this is what it says we're doing. And so don't let, us, the people who write these things down, end up misrepresenting. So if there's pieces of this that you feel aren't being represented, if there's overcommitments, this will be the time to talk with your work groups and make sure you're honing in on what really can be accomplished. All right, I'm going to move along for the sake of time because we've got a lot to cover this morning. But one of the things we really wanted to highlight for this group, and I know that it's because it was a proposal, it's been something that we haven't talked a lot about here in terms of the nuts and bolts. But the good news is, I think all of you are aware that there is a proposal for the blueprint expansion that's gone to the legislature this year. And what Kathy and I and Mo and others were happy to see is that there seems to be a lot of alignment with Blueprint's proposal and the work we're doing here. And so we wanted to walk through a little bit of this, of what's in the blueprint proposal, just to make sure people are aware. And if you haven't found these connections, let's make sure we are, so that we're working in tandem here. What we don't want is to have a bunch of decisions being made outside of this group, and then decisions being made in this group and having them not inform each other. So for the Blueprint for Health, their proposal talked about how it's a critical time to reinvest and redeploy healthcare transformation infrastructure. And so they're really still focused on a couple things that are indicators of poor well-being in Vermont. And one of those is death by suicide, and another is by drug overdose. So those are still two major indicators that this group will be looking at. And I know others are looking at that as well. And so obviously they're focused on access, as many of us are, and they're looking to improve access through increased integration with primary care. And the funding in particular will be for expansion of community health team capacity. And that'll provide co-occurring mental health and substance use screening, brief intervention and treatment, as well as navigation to services. So those are kind of the early nuts and bolts. If you can go to the next one, Kathy, I'll just finish up on what the blueprint proposal is talking about. So another piece is strengthening hubs for medication-assisted treatment. And so I think for people who maybe aren't that aware of what the hub and spokes can do, there were some limitations on how to serve someone who might have polysubstance use disorder and co-occurring mental health. And there's been a strong sense that we want to, if we say we want to meet people where they're at, if they are coming to those doors for MAT, that it would be a great opportunity to also be able to serve for some of these other needs. And so the pilot would increase investments for community health team capacity for both mental health and substance use disorder treatment, for the hubs to do co-occurring and polysubstance use services, and that if that's all successful, we would consider ongoing Medicaid funding and expansion to commercial insurers. So I'm going to pause there because I'm hoping that when people see that, they will see a lot of spaces for this group to be involved, to be talking about what's on the page there, to be ensuring that if this goes forward, how does that impact everything we say our work groups are doing? I'm hoping that every one of you has some connection or way of talking to someone involved in the blueprint expansion. And now that, these things are transparent, that you're having those conversations. And if you don't feel like give a space to do that, please let us know so that we can build those tables. Give everybody a chance to digest and see if there's any questions before I highlight something at the national level.
Allison, if I can just maybe name an elephant
All right,
in the
I'm
room.
going to see if I can deepen my voice and talk like Dr. Levine now, because this is where he would be taking over. But Kathy, do you want to go
Can you hear
to the VA report?
Sorry, Laurel
Okay.
was trying to ask something.
If you're like me, you had ample time to read the entire
Uh-huh.
VA report that Kathy sent. Oh, I see a hand. Mary Kate.
Allison, I'm not sure. I don't think you can hear us. We're able to hear other people talking.
Yeah, Allison, you're not hearing any of us, are you?
I just texted her.
Okay.
Try that again, Mary Kate. I couldn't hear before, and I'm hoping I fixed it.
There, can you hear now?
Yep.
Okay. That was all we were saying, was we could hear you, we could hear everyone else, but you couldn't hear us.
Yeah, Allison, I was going to pipe in, if I may.
Please do.
And I think someone might have wanted to say something earlier too, but I was gonna kind of name an elephant in the room related to the blueprint, which I thoroughly am excited about what's happening with blueprint. I think the biggest concern is just workforce. And so we want to make sure that we continue to have that focus on how do we entice more people into the work instead of kind of drawing from the same pool of folks that are currently here. So I know that's part of the conversation. I just wanted to name it in this group.
Thanks for doing that. I think one of the things we're going to talk about today is that we're really hopeful that this group has seen each other so much over the past year and a half that they're going to say stuff like that in this room. So really appreciate the modeling there, Laurel. And one thing that's nice about our work group is in the workforce development is we have people from the different sectors and we're kind of all staring at each other like how do we make it so you don't take our staff and we don't take your staff, and it's a tricky conversation. And so yeah, I'm gonna leave it like you without an answer, but I'm glad you said it. Who else has tried to
Allison?
talk while I couldn't hear you?
Yeah, Nicolette had his hand up.
I had a similar comment when we talk about increasing integration or increasing coordination. We also need to sort of talk about increasing capacity within, because otherwise we're just sort of shuffling around. So I appreciated that comment. Thank you.
And Mike has his hand up.
So I don't have my thoughts fully formulated, so I'm sort of thinking out loud a little bit here. I am afraid that our value of primary care, of everyone being attached to and being organized around primary care, is not true or is a fantasy. That more and more, or that many people, maybe always, are not organized. They don't have their care organized around a relationship with a primary care doc. I think for sure there is a segment of the community that is. I think there's also a segment of the community that's organized around other areas of care, be it a designated agency or another community organization. And I think there's a whole segment of the community that's not organized, that isn't connected with any formal organization. So I have a little fear of our whole discussion being about integrating or accessing people or improving their care through their relationship with primary care. Might be a little bit sacrilegious, but that's a basic concern I have.
Does anyone have thoughts about? Yes, Andy.
Yeah, that strikes right a chord in my heart and brain and every part of my body. I think that as long as we continue to have two parallel systems, it's always going to be a problem. And what I would love to see, which I've argued everywhere I ever can, and probably won't happen, is to have a merger where it becomes one organization rather than two. Then you don't have to talk about sharing staff because it's all one staff. You don't have to talk about who does what because everybody's working together. I mean, that's it's sort of the holy grail of integration. I've seen it come close, but when it gets down to the nitty gritty of, actually making it happen, it hasn't happened. But if we could ever get to where we just had a single healthcare entity in even some small place, I think it could answer a lot of these problems we're trying to address.
Yeah, and I think the VA report is going to talk about that a little bit. I can just say, since we're speaking frankly, that I think there's a lot of people who are really afraid of having things absorbed into healthcare if the healthcare model is as it has been, which for many people feel like isn't driven by their specific personal needs, but is driven by billing or diagnosing or things that don't feel human to them. And so how do we merge without whitewashing?
I agree.
Mhm.
Both systems need to make some fundamental changes. That's the rub. Part of the rub.
Allison, do you see John Soroyan's got his hand up?
Thank you. Go ahead, John.
Oh, good snowy morning to everyone. A few things. Wasn't as ready as I probably should have been to address these things, but I'm ready now. Integration into primary care of mental health and substance use disorder is statutorily required of the blueprint with any new proposals that we make. This group and specifically Kathy have been really instrumental in giving me those different references. Secondly, there's a large document that I attached to my testimony of the proposal showing the value of integration, not just in Vermont, but multiple states and internationally. And I encourage people to reference that. And then thirdly is that I, as the executive director, am very aware of these issues and have been having multiple discussions with folks at DMH, this group, and more to come in the future. And then the last thing I'll say, because I'm sure, Allison, you want to move on, is that this investment reflects a time in community health teams at Blueprint when in 2014, there were over 140 FTEs for community health teams. Currently, there's less than 120. So while the investment is significant and seems significant, when I look at the numbers of people around the state that will be able to be funded for these dollars, in many of our health service areas, it's 2 people. And yes, that matters. But I think given how much community health teams have shrunk in the last 10 years, this is still a timely investment and one that can be integrative and can be collaborative and one that can be good for all. That probably seems naive maybe to many of you, but I don't think it is. I think it's well grounded.
Thanks, John. Great. So yeah, and I think what came together today was, not so much me trying to be an expert on the blueprint. So I do want to honor that if you have real questions about their proposal, you should be going to the source, but making sure people are aware that this is out there and that the work that we're doing does seem to tie to it. So that's our goal today. And we did want to highlight this VA report because I think it's really important. So as I mentioned, you should have this in your inbox. It's very long. I myself have not read through the whole thing. But if you haven't had a chance to scan it at some point, it's definitely worth a read. It certainly has something to do with each and every one of you. And so what we wanted to highlight in this is that this was a new report by the VA published by the National Academies of Sciences, Engineering, and Medicine. And the goals of it and the recommendations go beyond the VA. And it's talking about the movement towards whole health and the recommendation to scale and spread whole health beyond the Department of Veterans Affairs. And so, they're naming departments and areas in which we should be looking at, including Health and Human Services, federal agencies that are involved in social services, and external environmental actors like educators and corporations. And so there's a real push to say we've got to be doing whole health care. And to achieve this, we need a team-based approach, interprofessional, and anchored in trusted longitudinal relationships. So I think that goes back to Mike's point about, is that for everyone their primary care? But to make sure that they have a home base of health care and whole health promotion. And that obviously the things we talk about, not just intervention, but prevention, promoting resilience, restoring health, and that it's aligns with the person's mission. So if you could go to the next slide, Kathy. These are the spaces that they identified. So this is their list. And we were intrigued to see that it's pretty close to the list that we've made. But we did want to highlight a couple things that were slightly different. One is on number 1, it says people-centered. We've chosen the term person-driven because we decided that the language mattered, not to just put the person at the center, but have them being a decider and driving the care. If you look though at their definition of people-centered, they also get that as well. So I think we're talking semantics, but for us, it was a value to use those terms. Number 5, grounded in team well-being. We've talked about this a little bit, but I think we probably need to talk about it more. And this is provider well-being. So I think about the fact that, one of the things I find myself saying all the time now, whenever I give a speech, is everyone has mental health, and this is not about other people. This is about all of us. And in that same way, how many providers and teams do we have that are doing well enough to feel that they have something to give to an individual who needs whole health? And so how are we building that into all the pieces? Erin, go ahead.
Thanks, Allison. Yeah, noting your comment that it's semantics, I just wanted to say I've heard the term person-directed as a commonly used term in the developmental disability space. So just another word to throw out there for consideration.
Great, thanks. So we thought it was good news that we're close here, but also, putting our own Vermont spin on things. And then any other comments about this list? Hopefully it feels, like something recognizable to people. I think we've been talking about these ingredients for almost 2 years now. All right, Kathy, you can go on to the next piece. Okay, so one of the interesting things about this report is that they identified 7 innovative models that shared important characteristics of whole health. 6 examples were international whole health implementations. 1 was the Vermont Blueprint for Health model. So it was the only US implementation of its kind to be recognized in this report. And so I think what that said to me is sometimes Vermont can be pretty hard on itself. Like I've noticed coming from other states, other big states like California and New York, and spaces where you can't even get an audience with the people who make these decisions. I sometimes notice how really mission-driven and connected and good relationships Vermont has, but we are still sometimes act as if we don't have those ingredients. And so I found it intriguing to see how well this program was regarded. And within Vermont, we're still quite critical of a lot of the programs we're developing. I think that's a good thing. But just for people to be aware, nationally, this was really lifted up. And the reasons why were because they felt that it advanced team-based primary medical homes as a locus, which I think
Did the audio cut out for anyone else?
Yes,
Yes.
Allison's frozen for me. It sounds like I didn't know if it was me or everyone else, or Allison.
Well, power is going out. I know my power just went out 5 minutes ago and I had to switch to my iPhone.
Great.
Looks
And
like
soon I will
others
lose my
at the main
computer.
office are frozen too.
Same. This is Cheryl. I just lost power too. I've lost Teams and everything else.
Oh, great.
Yeah,
Great.
I'm
starting to
I'm
happen.
texting. Sorry, I'm texting with Allison. She said the internet went out. I'm going to ask if she can call in. Vermont storms.
I just want to acknowledge we've got our OneCare team here. They're being very patient. I really appreciate your you're being, and I'm glad you're here for this discussion too. Josiah is always with us, of course. But Alicia Jacobs and Derek Rains, I saw also have logged in a while ago. So, I mean, I can continue this, but I'm very interested in Allison's reflections about this. I mean, I'd rather we got her back.
Kathy,
Hey, there you are.
can you hear me?
Yes.
Coming in
Yes.
by cell phone.
Okay. Can you, will it
All right,
work for
well.
you to continue?
Sure, yeah. Go ahead, just, I'll keep going and you just change slides when you need to, but I'm gonna look at it from my end.
Great, good.
Oh, okay, so I think we just wanted to talk about, like, here's why the VA chose this and here's the ingredients that they picked up on. And so there was a feeling that there was a focus on improving patient experience and self-management approaches. I think the self-management piece is something that we probably haven't talked about a lot in some of our groups, so that's something we could pick up on. Focus on person-centered care, and then augmenting the move to advanced primary care, that they established community health teams to support broader provision of work